So even if in theory everything sounds quite clear, there are certain situations where the assessment of diastolic dysfunction might be more difficult. I will show you which situations these are and how we can go about if we encounter these situations. One situation which you will frequently encounter is that you will find fluctuations in the size of the E and the A wave and variations with respect to the relationship between the E and the A wave, usually caused by respiration. This can be found particularly often in patients who have chronic obstructive lung disease, and it seems to suggest that these patients have high normal filling pressures with E to E ratio somewhere in the range of 8 to 9, maybe even more. Another situation which you will encounter is that you will have fusion of the E and the A wave in patients who have fairly high heart rates. In addition, a long systole, as for example in patients who have dyssynchrony caused by left bundle branch block, can also cause fusion of the E and the A wave. Another cause for fusion are long AV delays, in other words, AV blocks. In these situations, it's sometimes difficult to determine if the patient has a restrictive filling pattern or an impaired relaxation. What you can do in this situation is that you perform a carotid artery maneuver. However, be careful. If someone has a hypersensitive carotid sinus, it could also lead to asystole and bradycardia. But here you can see what happens. Here we have the fusion of the E and the A wave, and with carotid massage, all of a sudden, we have slowing of the heart rate, and we have delineation between the E and the A wave, and now you can clearly see that the patient actually had impaired relaxation. So what you see here is a pressure tracing of an L wave. The L wave is located between the E and the A wave during diastasis, and it denotes elevated left ventricular filling pressures. In other words, even during diastasis, we have an elevation of the left atrial pressure, which pushes the mitral valve open. You will find this curve very frequently in patients who have bradycardia, and also in patients who have short AV delays, and even in patients who have atrial fibrillation. Very commonly, you will also see it in patients who have left ventricular hypertrophy. If you have a patient who has an E wave which is taller than the A wave, and you're not sure if it is a normal or a pseudonormal pattern, but if you see an L wave, you can be quite certain that it really is pseudonormal filling, because the L wave, as I already mentioned, denotes elevated left ventricular filling pressures. The next problem, what do we do if we have atrial fibrillation or atrial flutter? Well, first of all, it's a very common finding, and as we all know, left ventricular filling pressures or elevated left ventricular filling pressures cause atrial fibrillation and flutter, so there's a strong association between the two. Since we do not have an A wave in this condition, we cannot assess the E to A ratio. It's also very difficult often to look at the pulmonary venous flow in these patients, so the only thing we can really do is we can look at the E to E ratio or E to E prime ratio and use tissue Doppler. There's now sufficient evidence in the literature that we can actually use E and E prime in patients with atrial fibrillation. We know that the E to E prime ratio increases with the severity of heart failure, that E to E prime is better than BNP and the left atrial area to determine filling pressures, and that E to E prime declines with the improvement of heart failure. What about left ventricular filling pressure and mitral valve disease? Can we estimate left ventricular filling pressure? Well, the left atrium is not a very good parameter, since it can be enlarged simply because of volume overload of the left atrium or because the patient has atrial fibrillation. So the left atrial size does not necessarily reflect elevated left ventricular filling pressure. What about the E wave velocity? Well, in mitral valve disease, the E wave velocity is also influenced by other factors, such as stroke volume. In patients with mitral stenosis, you will have a fairly small E wave, while patients with mitral regurgitation, due to the increase in stroke volume, will have a tall E wave. So in summary, you cannot estimate left ventricular filling pressures in patients with mitral valve disease. So in summary, if you have fluctuations in the E to A wave ratio, use tissue Doppler. If you have a fusion of E and A wave, try to lower the heart rate. If you have an L wave, it usually means you have elevated filling pressures. If you have atrial fibrillation, you can use tissue Doppler. And if you have mitral valve pathologies, the E to A ratio is actually no good.